Hello everyone and welcome to the first edition of our Micro Steps seminars. My name's Anthony, I'm a psychiatry doctor in Greater Manchester and I'm a proud ambassador of the charity UOKDoc. Firstly, a huge thank you for everyone for attending and also to Paul Farmer for generously donating his time. We're excited to have attendees from across the US, the UK and the rest of the world. For those of you that don't know, UOKDoc is a charity that's focused on mental health and well-being for doctors. And this seminar is brought to you by UOKDoc in partnership with First Responders First, which is an initiative of Thrive Global, and Harvard T.H. Chan School of Public Health and the CAA Foundation. The purpose of the webinar series is to bring together leading voices, such as our guest today, to help promote and support the mental health of medical professionals and help them empower themselves. This is obviously an extremely important issue in today's challenging world and for the long term. So we hope the series will help bring some needed guidance and hope. Moving on to our guest for today, I'm privileged to introduce Paul Farmer, the CEO of the inspirational charity Mind, where he has been CEO since 2006. During his time at Mind, he has helped revolutionise mental health and challenge the stigma attached to it. So we are looking forward to talking to him about how we can do the same for mental health, for medical professionals. Your host for this evening is Chris Cherry, who is a founding trustee of UOKDoc, and he's a psychotherapist with 30 years experience. This webinar today is live and Paul is very keen for you to send in your questions, so please do so on the chat function. We are very proud to be able to offer this webinar for free. However, as a charity, we do rely on donations to survive and to continue supporting the mental health and well-being of doctors. If you wish to donate, the text donation details will be in the chat function, or you can head over to the website, UOKDoc, for further information. Finally, a huge thank you to our partners, First Responders First, and our sponsor, Draeger. Without them, this wouldn't be possible. And now, without further ado, I'll pass you over to Chris.
Thank you, Anthony. Welcome to everybody, and particularly welcome to you, Paul. Thank you so much for being the first speaker conversationalist in this next series of webinars, particularly focused around microsteps. And to the audience, I mean, one of the things that we very much wanted to encourage people to do is take the opportunity to ask Paul some questions. I mean, the format is I think it's been presented as 45-minute conversation with 30-minute questions and answers. But I think in conversation with Paul, we're very keen to bring people in on the conversation. So do send questions in from the beginning and we will start to include them as part of the overall conversation that me and Paul are having. So welcome, Paul. Thank you for joining me.
Hi, Chris.
You know, one of the things I thought just in preparation is, I mean, I sort of know what Mind is, but just say a little bit about Mind, because it's useful for us as just to be reminded of the importance and the history of Mind.
Yeah, well, thanks very much for having me, first of all, and it's a real pleasure to be here, as it were, in this Zoom space. Yeah, so interestingly enough, our Mind's 75 years old next year, so we'll be celebrating 75 years of existence. Formed after the Second World War by a forced merger of 3 other pre-existing voluntary organisations. The government of the day was worried about the psychological state of the country and asked these organisations to come together to form the National Association for Mental Health, which is still technically our sort of operating name, our legal name. And ever since that time, we've been a charity that has, really sought to stand up for people with experiences of mental health problems, for families. And interestingly, we also were heavily involved in the very early days of training of health professionals as part of mental health professionals as part of our body. Fast forward 75 years, and we're a national charity with round about 120 local minds. So for those people who are watching from England or Wales, we have a local mind round the corner from wherever you might be. And between that network, an extraordinary federation of charities, we support round about 500,000 people every year. And in addition to that, as a national organisation, we're really about changing the way that we all think about mental health, whether that's influencing government or providing people with information and support, or working in workplaces or influencing the media in their behaviour. And so we continue to do that through thick and thin, and probably best known for being, I think probably by most people, for being an organisation that is about campaigning and changing the way that we think about mental health, but also providing one-to-one support. And I've been very lucky to do this job for 14 years. I consider it the best job in mental health.
Yes, I mean, I hadn't quite realised you'd been heading the charity for 14 years. What have you particularly noticed the changes that have taken place over those years?
Well, I think the sort of biggest shift in the work that we do has been the influence, I think, that we and many others have had on public awareness and public attitudes about mental health. I've worked in charities that have worked in and around mental health for the best part of nearly 30 years now. And certainly when I started, nobody wanted to talk about mental health. It was very much a taboo subject, and it was an issue which really people didn't have the language to talk about. And I think that's certainly been one of the areas where over the last 10, 15 years, we've seen a change, and we've stimulated that, I think, by running large scale campaigns like the Time to Change campaign, which I'm sure we'll talk about at some point in the course of this session. And also by challenging poor practice where we see it, whether that's in the media or in employer behaviour.
And what would that be? What would be poor? Sort of, you're talking about attitude, responses, views of emotional well-being.
Well, let me give you two examples of that really stick in the memory from in terms of depiction and in terms of behaviour. So we're entering autumn, and it won't be very long before we get to my least favourite time of the year, Halloween. And every year, somebody somewhere makes a retailer somewhere markets a costume which they will call schizo killer or asylum inmate, and it'll be a costume with blood, and you'll be able to get a fake axe and that kind of thing. And 6 or 7 years ago, ASDA did just that, and the sort of Time to Change movement rose up as one and said to ASDA, on social media, are you really doing producing a product like that is so stigmatizing? And 2 hours later, they pulled the product, and that was a sort of victory for a shift in, this is a totem for a shift in attitude. The other example in employment practice, I suppose, one of the things we've seen over the years is where people are actively discriminated against because of their mental health. So again, another high profile case where we supported a young woman who had worked for an airline as a cabin crew, and she'd been sacked by her airline because she'd experienced depression, and that was clearly discriminatory and unfair. And so we work with that person to call out the poor practice. So I suppose those are 2 examples of what we mean by poor behaviour. And of course the media is often one of the primary, has historically at least been a primary culprit in depicting people with mental health problems in a very kind of singular way, really.
I mean, I can see it. I mean, over the years, but as a therapist myself, I can see people's being more comfortable in some ways to talk about being in therapy, or wanting to pay attention to their mental health, or to understand themselves more sort of deeply in terms of how life is playing out for them, and as well as sort of advocating and educating people and making it clear what is good ways of looking at mental health. What are the positive things that have been built upon that you see mind having been brought to the debate, the conversation?
So I think one of the first things is we've tried to shift the conversation from simply being about mental illness to talking about mental health. And when we talk about mental health, to mean mental health. So I know this session is all about micro steps. So, you know, one of the simple micro steps we encourage people to do is to think of 3 things that you do to look after your own mental health. You know, we spend lots of time now thinking about our physical health. You know, lots of us will have wearable watches that will tell us how many steps we've done. We'll be constantly thinking about how many glasses of wine we've had or how many calories we've consumed. But how often do we think about the 3 things that we do to look after our mental health? And I think that sort of conversation where we're shifting, I mean, of course, we're not moving away from wanting to talk about mental illness, but encouraging more people to think about how you look after your mental health, how you thrive, is a really, perhaps a really good example of that. And you know, if that's not something that you do, you know, think about that simple micro step, and whatever environment you're in, those 3 things that you can do to look after your own mental health.
Mm-hmm. And then within the medical field, I mean, because you have such a broad range of experiences and insight and understanding around mental health and emotional well-being, what's your sense of the medical field in terms of its ability or willingness or engagement with those important elements of doctors' lives?
So I think we knew very early on that one of the areas of stigma challenge, if you like, around mental health still does lie within the medical profession itself. And I think it's quite complex because, you know, first of all, people who come to work in medicine go through their medical training, their practitioner training. Not many of them, in truth, will have much mental health training, even at a most basic level. Obviously, some people will do a psychiatry rotation, and obviously some people will increasing in numbers now, I'm pleased to say, will choose psychiatry. And psychology is now a huge growth area, especially at further education level, at a higher education level. I think isn't it one of the most taken A levels by sixth formers. So we've got this kind of greater level of interest, but we have heard often that the environment in which doctors and medical practitioners practice often makes it very difficult for people to be open about their own experiences, their own mental health. And why is that? Well, partly that might be because there's a culture that says it's not good to show your own personal concerns. We've done a lot of work with blue light personnel, people in police, fire and ambulance services.
Yes.
And we certainly heard from them this sort of requirement to put on your mask of resilience, if you like, where you're not really, where it's difficult or even disapproved of sometimes to show how you're really feeling. Secondly, I think there are complexities sometimes about how people feel about their mental health status in relation to their job. So we've certainly heard historically of people who've been worried about the impact that being open about their mental health might have on their fitness to practice. And then thirdly, people operate in very difficult working environments. And my goodness me, in the last 6 months, we've probably seen that more than ever before. But I think sometimes those environments don't necessarily encourage the kind of support that often can take place within a more conventional workspace. So there are sort of some environmental factors at play. And I remember very, very clearly a couple of years ago walking along a corridor of an acute hospital, I won't name it now, going to take my wife for some treatment. And I walked past a board and it said at the top, staff well-being. and it was an empty board. There was nothing on it. I thought it was a bit of a metaphor for, I think, the way that historically we have often looked at this issue. Now, I actually do think things are really changing, but I think it's taken a very long time for us to really recognise that if we're really going to cherish and value our medical clinical staff and indeed non-clinical staff inside the health service and health systems generally, we really need to pay attention to their mental health just as other employers are doing.
I mean, I suppose, well, I mean, that's a fundamental reason for UOK existing, really, is to educate, inform, and in a way normalise the conversation to remove the stigma or the prejudice or the fear of how one would be seen. I mean, based on your experience of other environments, can you see clear things that the medical field could take and draw upon, utilise within their own culture?
Yeah, we do a lot of work with employers in both the public and private sector, and we run both a kind of pledge tool called the Mental Health at Work Commitment, which has been signed up by about 500 employers, many large employers, but some small, including 7 healthcare organisations in the NHS. And also we run the Mind Workplace Wellbeing Index, and that's a sort of benchmarking tool for giving us really good ideas or good indicators about what constitutes a good mentally healthy workplace. And there are 3 or 4 kind of ingredients that I think you need to have in place to really make this work. I mean, the first one is a leadership culture that supports an open approach to mental health. We know that in other parts of, and to some extent in the health system of business, senior leaders opening up and being honest and open about their own personal struggles or at least giving permission to other people to do that as well, makes a big difference. It creates a culture of permission. Secondly, connected to that, having mental health champions inside an organisation, we know makes a big difference too. And these are people, again, who have got their own lived experience. They're prepared to talk about their own experiences of mental health problems, and they kind of operate inside inside an environment where they're encouraged to do that. We've now got, for example, around about 5,000 blue light mental health champions, people who work in those blue light services, who are being open about their own experiences and just there sometimes to, provide a little bit of confidential, quiet support for somebody. Thirdly, having a kind of approach that thinks about all staff, thinking about the mental health of all staff in a team. How do you help people to thrive? And that comes back to the first micro step of thinking about what you do to look after your mental health positively.
Yes.
Fourthly, having a kind of support for supervisors when they notice that somebody might be struggling. You're sort of your people know their teams better than anybody else. They know when somebody's not quite right, when maybe they need that arm around the shoulder, just checking that they're okay. But they also need the tools to be able to have that conversation. And then finally, and I think this is particularly important for in a clinical setting, is there a really clear pathway for people who are unwell, who have got emerging mental health problems, to be able to go and seek and receive appropriate care and treatment in a timely manner? So those are the sort of, from our work in other spaces, they're the sort of active ingredients that really make a difference. And some great examples in some unusual spaces. The construction sector, for example, has really taken this to heart as an issue.
Well, why have they taken it to heart? How have you managed to get them engaged and motivated and see the positives of engaging in this area?
Well, I think in the case of construction, it takes, in this case, the sort of the model works. There are a few champions at quite senior level, people who had had their own lived experience. But the biggest single factor for that group was that they realised after the they're very, very proud of the safety record that they have in this country around very, very low incidence of site deaths or deaths as a result of on-site accidents. So everybody will remember the London 2012 Games was the most successful from not just from a medals point of view, but from a site safety point of view. They were very proud of that. And then they found out that the number of people in the construction sector who died from suicide was 10 times that of the number of people who were dying from site accidents. And they sort of almost resolved to really think about this issue in a, as a sector. And it's not the sector you'd imagine would do this. It's a very male-dominated sector. It's got a very complicated workforce arrangements because lots of people don't work for the big construction companies. There's lots of contractors down the line. But they have really taken this issue to heart and identified. And it's been our job in these circumstances nearly always just to come alongside a sector and help them do the right thing, and help them identify the champions, identify the tools they need, and they now run there's a number of initiatives, but one of which called Mates in Mind is a 45-minute intervention that's run on a building site. A guy in a hard hat goes in, sits down with the crew on a lunch break and runs a very simple 45-minute awareness raising session on mental health. And the results are looking very promising overall for the sector. Where certainly it's had an impact on things like sickness absence, and it looks like it's beginning to have an impact on suicide rates too.
I mean, in a way, you're talking about creating environments in where it becomes more, people can be more comfortable. It doesn't have to be so dramatic. I mean, obviously, some of the situations people will, by their very nature, be dramatic, but just generally talking and beginning to be okay to talk about these things, not just people who are struggling in the moment, but also inviting people to attend more to their general mental, emotional well-being as part of I suppose, you're inviting people to be kind and caring to each other, about the quality of people's lives, as much as using them as workers or to produce goods or whatever. What have you, in the process, what have you learned as a charity is the best ways to inspire, to motivate, to bring people in, to get them curious about this?
Well, I think the first route is to be open and inviting, and to create those safe spaces. And sometimes those safe spaces are virtual safe spaces. And we've been, although I'm sure I hope we'll very much get into a debate about the merits and relative merits and ills of social media. I think we've found that for many people, their social media network has been a place where they've been very open and they've felt trusted. And we, in the very early days of our work in workplaces, we set up a Facebook page, called The Elephant in the Room, and people just used to come and talk about their experiences. We were really, surprised at how open people were, but it was because we'd created that safe environment. And then also, sorry, no, go on.
Just, I mean, that sounds. Just say a bit more about the elephant in the room.
Well, yeah. So 10 years ago, after just in the wake of I suppose what we're now going to call the last economic crash, we started our work on workplace well-being, and we did it partly because of the economic circumstances, but also because we were really understanding the importance of the workplace as an environment where we can all learn about our mental health. Because, I mean, if we were in a room now, I would probably be asking the audience to put their hands up if they ever had any mental health education at school. And unless you're under the age of 20, the chances are that you probably won't have done. So what we did was to try to start to think about how do we engage workplaces, and we found very early on people just were not talking about mental health in their workplaces. They didn't want to. The stigma was very strong. So we devised a campaign called the Elephant in the Room, and it was it's a kind of humorous campaign about how there was this enormous kind of pachyderm in the corner that called mental health that nobody was really talking about, but didn't really know. People didn't really know how to talk about it. And the elephant was then had a Twitter character and a Facebook page, and the Twitter character was sort of dispensing tips like, make sure you go and have a lunch break or go and talk to your friends. And also the Facebook page created a space for people just to come and pose questions. That grew so much that it now, in fact, we're just on another iteration of this, but we created a whole digital peer support platform called EliFriends, which right up to very recently had over 100,000 regular attendees, people coming and not just talking about workplace by that time, actually evolving into a safe digital space. So there's a lesson for us about safety, about people being comfortable. I think there's a lesson also about permission, in the space, in the environment that you're operating in, to be able to talk about it in a safe way, because people are still afraid of reprisal. It'll being open about your mental health will damage your promotion prospects, or if there's a redundancy round coming up, you'll be the first in the queue. So it's really important that you create that environment that means that people feel safe talking about something which is often incredibly, it's one of the most personal things that we do, is to talk about our mental health.
Yes. I mean, do you see do you see things having improved? I mean, the way what you're talking about, and from what you're saying, things have improved hugely in the last 15 years or so.
Yeah, I think generally we know the public attitudes has improved considerably. We've got great evidence. We track public attitudes every couple of years or so, and public attitudes improved. And in workplaces, I think what we would say would be that there is a vanguard of probably 15 to 20% of organisations who are who are doing some really good work in this space. I think there's a kind of bunch of organisations who are definitely doing something, and probably that's maybe 40 to 50% of organisations doing something. And we during coronavirus, we polled employers generally and asked them whether they'd done anything for their employees' mental health, and just over half had, and so that tells, I think that's quite a good litmus test. And then there's probably another 20 or 30% for whom this is still, they haven't really got the memo that this is an important thing to think about. And we worry about those workplaces because those are sometimes the workplace. Sometimes there's a good reason why it's just not possible. Small businesses will find it very difficult, but those may also be the workplaces where there's most psychological damage being done to people because they're operating in workplaces which don't really think about the mental health or the well-being dimension to their people.
I mean, certainly as a therapist over that 15 years, there's much more comfortableness to talk to friends, colleagues, family members about being in therapy, and seeing the positives of it. I mean, you mentioned COVID. I mean, just broadly, what do you see the impact on mental health, emotional well-being that COVID, that is ongoing? We have started the next chapter of it. I mean, what do you see both having happened in the last 6 months and your sense of what we need to pay attention to and address in the coming months?
Well, it's been tough, hasn't it? It's been tough for many people, and for some people it's been dreadful, life-changing circumstances. And I think what we've, right from the start, we've been concerned about three groups of people in the broadest sense. People with existing mental health problems, And we know from evidence that surveys we've run over this period that broadly kind of around about 2/3 of people with existing mental health problems say their mental health has got worse during this period. So you're coming into COVID with a mental health problem. It's been incredibly tough and very challenging. The second group we've kept an eye on have been people who are more at risk of developing mental health problems, and we've included in that particularly the health and social care workforce because of the extreme situations that people have found themselves in, but also people who are particularly affected by COVID, people from Black and minority ethnic communities, people maybe who have been living in abusive households, and now increasingly people who are affected by the economic consequences of COVID. And we're worried about that group. And again, there's emerging evidence that that group are tipping over, a good proportion of that group are tipping over from being anxious and worried to having full-blown mental health problems, if you like. And then the third group we've been concerned about has been the general public. But interestingly, the data is suggesting that, broadly speaking, the general public's well-being in the first period, at least, has held up very well. And again, we think that's partly because the greater level of awareness means that people have been thinking a bit more about how to look after their mental health. But also some of those upsides of COVID, the greater sense of community, people looking out for each other, I think has probably had a protective effect as well. In terms of what comes next, I think we are, in fact, probably we're a little going to be slightly more concerned about the public, because this is going to be a really hard 6 months, if that's what it's going to be, and people's resilience has been deeply drawn, and some of the protective characteristic factors that lots of people have used in the last few months, like being able to take advantage of what's been good weather, won't necessarily, to do physical activity won't be necessarily quite so easily accessible. For people in that at-risk group, I think we've really got to pay attention to them, and we've set up a service called Our Frontline, particularly for people who are frontline workers, which I'll perhaps touch on a bit later on. But we're particularly worried about other people in those groups, and probably the strongest evidence of correlation in terms of mental health problems is related to financial problems. So if that plays out, that will be an issue. And then for people with existing mental health problems, I think my real hope, because I certainly hear this very clearly from the NHS services, is that NHS mental health services will stay open so that people will be able to get the help that they need. And that's going to be so important for people who really need good quality clinical care to support them during this next period. So yeah, so I suppose in shorthand, we're a bit worried about everybody, but I think there are particular areas of concern where where actually some actions could make a real difference.
And so the front line service that's been set up, just describe that a bit more, because that seems very pertinent for our audience.
Yeah, so as COVID started to take a grip in the early spring, we were hearing from some of our blue light contacts and others that frontline workers were experiencing a really tough time, and with huge credit to all the work that people have done during this period, it's bound to take there's going to be a psychological impact. And so we got together with Samaritans, the crisis text line service Shout, and Hospice UK to pull together a front door, really, to the support that we're able to offer. It's called Our Frontline. You can access it online at ourfrontline.org.uk, and it allows you to choose and find services and support that's available, because one of the things we know is quite often people don't necessarily know what is available, and it also provides direct access through to the 24/7 support of Samaritans and Shout. And so far, since this is one of those things that we used to take 6 months to do, to pull together, and we pulled it together in 6 days and got it up and running. And since we launched it I think it was in May, we've had over 150,000 contacts from across the health, social care, and also other frontline service personnel. And that could be whether that's a bus driver or somebody who was working in a factory, particularly during that lockdown phase. That service was open to all frontline workers. And we're going to we were going to see how things went, but we're going to definitely going to keep that service open for at least another 6 months now. And
what you're saying about the 6 months, 6 days, and one of the things about a time like this, people really they make things happen much quicker than before. Can you see the momentum? Can you see how you can build upon this? I mean, COVID is going to be with us for a chunk of time, but as part of the overall development of mental health and emotional well-being, do you see how you can, maybe in some ways just that it becomes another example of, look, everybody's going to be challenged by this. It's quite normal. We're inviting you to pay attention to your emotional and mental well-being, not out of stigma, but for the quality of your life and preemptive, proactive attention to your own care. Do you see how you can build upon that? Are there tangible ideas that are already forming?
Well, I think we have. I think so many people have recognised that that a physical condition, in this case coronavirus, has a mental health effect. There's a mental health dimension to coronavirus, and of course there's a mental health dimension to very many physical conditions, and that's often underplayed, I think. So I think increasingly we will see that recognition that there is a mental health or psychological dimension to many physical health conditions, that will become much more normalized. We know, for example, that if you provide access to psychological therapies for people with a long-term health condition like diabetes or cancer patients, that you can have a positive impact on visits to A&E, on in some cases on health management, and so on and so forth. So I think there's an opportunity to think about that in a much more holistic way, because we've begun, people I think have really paid attention to their mental health, and it's a kind of public level. I do think the program. Our worry, I suppose, is always that the progress that you make, like any cause, as we tend to think of as mental health as in many ways, that the progress you make is temporary or easily eradicated. But I think so many people have had their mental health tested in this period that that there's a greater public recognition that this is something we all have to pay some attention to. And so I think that maybe now allows us to think a little bit more about how we go on to tell that story, because we've only really just started. What we've done is raised awareness and some better understanding of what we mean and think of, but when we talk about mental health and mental health problems and mental illness, but we haven't really got into the depth of this at all. And I think the platform is now being created for more people to explore that. Who'd have thought that the BBC, 10 years ago, 10 or 15 years ago, somebody had said to me that a former England cricket captain would be fronting a television programme about his bulimia, which is what we're about to see with Freddie Flintoff talking about his bulimia. You would have said, really? That is never going to happen. But here we are with broadcasters being, commissioning programs with people talking about specific experiences, specific conditions, helping to take us to the next level.
Public figures, celebrities, sports people, in industry, commerce, different sorts of financial world, having people talk about their own experiences and then talk to other people, it's such a valuable, useful way to promote and educate, inform people, and again normalize it. And of course, someone like yourself coming on and just talking very straightforwardly. This is something for us all to pay attention to and to take care of ourselves. Do you have any? What would you see as some of the warning signs for people that you would if people are beginning to struggle in one way or another? What would you see as the warning sign?
Just before we come off your point about celebrities, just to say that those leaders are important, and for people who are interested in some of the academic work around this, Professor Graham Thornycroft of the Institute of Psychiatry in King's College London is the world expert on all of this. So do have a look at his academic work on that. Yeah, I mean, I think one of the really, I suppose this almost takes me to my second micro step for the for this session, which is about, do we know how our mental health is today, and can we spot the signs of others' mental health deteriorating? So a few tips to suggest. So first of all, we know that there are some common signs of people, perhaps if you're a bit less social, if you're a social person, you're being less social than you usually are. If you're finding it hard to concentrate on tasks that you usually find very easy, if you're having problems with sleep, and indeed you're sort of not looking after yourself in terms of your physical health or your kind of diet, and if your self-esteem is really kind of starting to fall, then those are all sort of early signs and symptoms that you might be that you're struggling. So our sort of first kind of conversation has been about how do we help people to thrive. What are those three things that you can do to look after yourself? Secondly, what are the 3 or 4 indicators that you might be struggling? And of course, for different people, it will be different things. It will be maybe having a couple of extra glasses of wine in the evening because you're really not feeling that great. It might be staring at a screen and realizing that something that you usually do in a second is taking you 10 minutes. It might be the kind of the decision not to really pick up that phone when somebody rings because you don't really want to talk to them. Those are all signs to be aware of and to pay attention to.
Usually, in my experience, it's not so much 2 glasses, it's opening, not my experience, but opening the second bottle. That's when people start to begin to realize that something's not right.
We have such a complex relationship with alcohol, don't we? And other forms of self-medication, I suppose. But yeah, I think that's often a sign. We did some work a few years ago with the barrister's profession, and we found a very high proportion of alcohol abuse connected to poor mental health, and partly because it was a culture that encouraged, where dinners were what people did and went to. So I think you absolutely have to keep an eye out on those things. And it's often if you're looking out for somebody, you want to be in your colleague's corner, then you'll be able to notice if somebody's just not quite the person that can make quite such a difference, to be able to pick that up at an early stage, so that people can adjust, do something for themselves, or get some help from friends or people around you.
I mean, in low mood, just someone, the dial's being turned down, they're just not engaging. I suppose going inwards, not feeling motivated, not feeling that there's much point to things, just not, the sense of energy or engagement begins to quickly diminish. The sense that things are grey, really, but there's no colour. And then going through the motions.
it's a sense of flatness, isn't it? And
yeah,
and really, often feeling as though you don't derive pleasure from things that you previously derived pleasure from. And it's one of the reasons we talk quite a lot about the importance of those sort of protective factors, because there are things that we all do that really help boost our mental health. And if we're not able to do them, then sometimes we notice a difference. So for me, for example, physical activity, cycling or running is something I need to do. And if I don't do it, I really feel the difference. But if I was feeling really down, I would kind of think, oh, I just can't face it. And so you're dropping ever deeper down a hole. It's a bit like being, in a sort of well with no ladder. And if you're in that sense, if you've got that feeling,
yes, yeah,
then that is the time to cry, to shout for help. Before things really overwhelm you.
yeah, yeah. I'm aware of time. We're going to have to let people in on our conversation, but just briefly, so frontline, if you go to the front, does that frontline take you direct to, or do you go through mine to get to our...
Our frontline is hosted on the Mental Health at Work website, which is a site that we run, but it's just it just takes you a front door straight into a kind of bespoke page for frontline workers, and you can click on the type of worker that you are, and that then takes you into a set of pages with information and support about how you can look after yourself, but also where you can get access to specific support. And it also then gives you an access route into the services offered by Samaritans and Shout. So it's a sort of I think it's what we call a portal.
Yeah, yeah. And then and then if people go to the Mind website, is there additional information, resources to check out?
Absolutely. The Mind website has an enormous amount of information on all types of mental health issues in very accessible language, and with lots of information and lots of referral points. And in addition to that, alongside the web support, we run a national information helpline, which is open 5 days a week, and we also run a legal information support service, because we know there's a lot of people have particular legal issues around their mental health, and we're able to support on a number of those areas.
So you'd give direct advice legally around your rights.
Yeah.
Okay.
Yeah, exactly.
Yeah. I'm going to have to give way and let people come in. We haven't done what we hoped, which was to bring people in during the 45 minutes. But right. Anthony, what are some of the questions?
Hello. So I just first of all want to thank you for that talk. It was really interesting. You might be interested to know, Paul, that the Mind leaflets are actually used quite widely in psychiatry, and we often use them actually to prepare for exams, because they're really good at expressing in patient-friendly language mental health conditions.
That's nice to hear. So have we helped you pass your exams, Anthony? This is
my great. Exam is in 3 weeks' time, so hopefully
we'll send you some more leaflets.
Thank you. So our first question is where do you think the responsibility lies with doctors' mental health, with the hospitals, with their peers, with the government, with the NHS, or with some external organisation?
Yeah, great question. Well, because you have you doctors have a very interesting employment status, don't you? So and this is one of the really interesting issues. So you're employed by who exactly? Are you employed by the NHS? Are you employed by your trust? I think you would probably say you're employed by your trust, but you're also in a wider sense employed. Who would you say you're employed by, Anthony?
So I'm actually a trade union representative, so I've got a funny answer to that. But in the Northwest, we're all employed by the same employer. Every junior doctor in the whole of the Northwest of England is employed by one employer, by St Helens Trust. But I do think it is quite complicated, because you have the role of Health Education England as well, which isn't an employer, but it does have quite a significant kind of role in ensuring well-being of trainees and that they are being trained. So it's not as clear-cut as it is in other industries, I think.
So, which is all the more reason why you have to have sort of touch points in every corner. So if it isn't simple and straightforward, then there's two ways to go about this. You either make it very clear that there is a single employer who takes that responsibility, and whether it's, you know, the NHS in its kind of biggest form, or an individual trust, or the trust that's employing the trust that's employing you at that time. You know, I mean, my personal preference is normally, and especially in large organisations, to get it as close to the local as you can, because it, you know, what goes on in a particular trust, you know, that will vary from place to place, and the culture in trusts will vary from place to place. But if you're, you know, at any point in your journey, you ought to be able to have touch points where you can access support. And I think that's really important in training. You know, universities have got a job to do here. We're just currently running a big pilot program in 10 universities at the moment, looking at kind of boosting all students, isn't just about med students, all students' well-being. So there's a university touch point, there should be the junior doctor touch point, the kind of consultant touch point, and so on and so forth. But ultimately there has to be a place that every person knows they can go. And I think even if you in the best employers, so, you know, construction industries being a good case, as we described earlier, or you know, some of the banks, they nearly always also have an independent employee assistance program that an employee can access, and that will often offer people access to counselling, you know, to people like Chris, to therapy in some cases, but also you know, other access to other things that connect, you know, like relationship support or financial support or those kinds of things. And I think you need to have both an independent and you know, and an employer space to address this. And, you know, most trusts do have quite large HR departments. It wouldn't take a lot to have, and we are beginning to see this now, bespoke well-being staff in those teams.
So the next question is what can I do at my local hospital, which I think is quite a tricky one because it really does depend on the local setup.
What was the question again? Sorry.
What can I do at my local hospital
to promote, to just as a promotion and helping? Yeah, as a because you've got I mean, by the way, just should say I really love what you're doing in UK Doc. I think it's the one bit I haven't mentioned earlier is this idea of, you know, the way that movements from the ground, if you like, really deliver change. And, you know, a lot of the reason why the Time to Change movement has worked is because it's been about individual people with their own lived experience who've chosen just to do something in their own space. So I'll interpret the question in that sense. So what do we encourage people to do? So, you know, to be a mental health champion, you know, I think there are a few things that you can easily do. When we say to employers, make the most of the events that happen, you know, on the mental health calendar. So there's, broadly speaking, 3 big events in the mental health calendar: World Mental Health Day on the 10th of October, Time to Talk Day in February, and Mental Health Awareness Week in May. And all the mental health charities produce great information material that you can use to promote in all kinds of different settings, including workplaces. So, you know, so I think there's something very kind of something you can do just to absolutely raise awareness of mental health in your local hospital, and you know, aimed at the staff in this case. I think secondly, and connected to that, we see mental health champions running lunch and learn events, or you know, increasingly these kinds of Zoom type events, hosting events, bringing, you know, local mental health charities, you know, Local Minds or whoever it might be, to come and talk about their experiences. There is you know, I'm pleased to say there's a growing number of clinicians who have been open about their own, at quite senior level, have been open about their experiences of their own mental health problems. And I think we need to encourage that more, because kind of bringing people into those conversations is really helpful. And then I think the third thing is you can just ask some really simple questions of your hospital, and of the leaders of the hospital. What is the policy about mental health of staff? Have you signed the mental health at work commitment? That would be a very easy thing to ask. And if you have, there's 6 kind of standards that you sign up to by signing up to the mental health at work commitment. What are you doing about those 6 standards? What are you doing to achieve them? And probably can I help? So that'll keep people busy. That sounds like quite a lot, but pick the things that make sense and find people who will support you. And one thing we always find is, if one person says, I've had my own lived experience, the chances are that 4 or 5 other people will go, yeah, me too.
Do you have some of your own favourite examples of raising awareness, or some of the ones that you felt really make an impact or a significant difference?
So the evidence, again, provided by the aforementioned Professor Graham Thornycroft, is that, and this is interesting in the context in which we're operating coronavirus, is that social contact is the most effective means of changing attitudes and behaviour. By that I mean bringing together people with lived experience of mental health problems who are able to comfortable talking about their experiences, and with people who don't. So in this self-isolation, non-social contact setting, that poses a bit of a challenge. But what we're doing tonight is an example of what we can do virtually, and that is easily the most effective tool. So the one thing I saw, which was absolutely brilliant, run by one of our local Times Change hubs in Norwich, was a thing called the Living Library, where they set up in a shopping centre a living library, and you could sit down. So instead of taking out a book, you could have a 15-minute conversation with somebody with schizophrenia, or somebody who experiences depression. And our champions, who we supported, would be happy to sit down with anybody, any member of the public, and have that conversation. And we know that kind of that social contact, as it's called, and it's a very simple idea, but we know that it has a material impact. And the 15 minutes, and in some cases 5 minutes, is the what you might loosely call the dose effect.
Mm-hmm. So I've got quite a few questions actually, so I suppose we better crack on. Do you have any experience of working with the Department of Health or top bosses in the NHS with how to filter good wellbeing culture down through this huge organisation? A lot of problems come from people in the positions of power or within our organisations who tend to share historical attitudes regarding mental health. A common attitude is, it was worse in my day, so what are you complaining about? And I have to say, I've definitely experienced that before.
Yeah, that's why leadership is so important. If the leaders are not signed up to this, things don't change. But I would point to, I would give a couple of examples. There's a guy called John Lawler, who's the chief exec of the, I won't get the name of the mental health trust right, but it's the one that covers Northumbria, Newcastle and Tyne and Wear. John has been incredibly open about his own experiences, and actively champions that within, not just within his trust, but actually more broadly across the NHS sort of leadership space. We do need more leaders like that to come out and be a bit more open, and in some ways that's one of the reasons why I think in some cases this sector has been a little bit slower. So I think there is room for more leaders to be more open, but we are beginning to see that, and it's definitely being encouraged. I think these days, if an NHS leader was more open about their experiences, or a leading doctor, in fact, several past presidents of the Royal College of Psychiatrists have been quite open about their experiences. Mike Shooter, Dinesh Bugra were very open about their own experiences, and I think that's the kind of clinical leadership. The thing I would really love to see would be a leading president of a non-mental health medical Royal College talking about their own experiences of a mental health problem. And I'm hopeful that we'll see that soon.
I've got another question here. So the Ministry of Defence have historically high rates of attrition due to PTSD, almost always as a direct result of warfare. Would you say burnout or PTSD, not to mention the very high rate of physician suicide, which are well reported in kind of healthcare professionals, is an occupational hazard? Or do you think that there are changes that could be done in healthcare settings that would help change this? And if so, do you think, if so, how do you think that access to a think tank, or what changes would be needed?
Well, I think we have to start with the assumption that many suicides are preventable, and therefore we must do, if not, in some ways you could argue all suicides are preventable if you intervene at the right moment, at the earliest, or in some cases the latest possible moment. So I think we absolutely have a duty. Employers have a duty to think really carefully about what you can do to diminish the level of suicides in any profession. And both physician and nursing suicides are high, proportionate to other occupations. So I think there are approaches that you can take to support people. And so for example, I mean, just to take the specific example in the question, if you develop post-traumatic stress disorder, it is not an inevitable consequence that you will take your life. Many people are well treated, well cared for, well supported, get really great care, and live a good life. The people who don't get the good care are the people who are more at risk. So the responsibility of employers is to make sure that care is there. And so the third part, thank you, it's the cue for my third part of my sort of triangle. So we've done the thriving, we've done the struggling. The final bit is the unwell. Have we got a really clear pathway in place so that people know where to go when they are unwell? And that's such an important part of this equation.
Thank you for that, Paul. I think one of the other things is sometimes people find it very difficult to talk to people who they think might be suicidal, or how to address it. There is the Zero Suicide Alliance, which has a short 20-minute training on how to approach somebody who's suicidal, which people might not be used to doing. We're quite used to doing it as psychiatrists, but it's very useful for anyone. I'd really recommend it. I've got another question, which is, I think that a way in which we start a mental health revolution is by avoiding the use of the term mental illness, since it doesn't really make sense to think of it as a medical disorder. What are your views on this?
Excellent. We've really got time for a conversation about the medical versus the social model of mental health or mental illness. But so I think it goes back to my earlier point. I think if we only think about the issue of mental health in the context of mental illness, then we're not really grasping the bigger, they're both big issues, but the biggest issue of all, which is, how do we think about this on a societal level? I think there is, as many people I'm sure will know, there is some contestation about the way that diagnostic labels are created and constructed around mental health. And we at Mind have often advocated a kind of a sensible approach to this, I think. And so you'll see, we do understand the utility of a diagnostic label for people, but I think we have to be honest about what that means. Essentially, a diagnostic label is a collection of symptoms, and that's helpful for a lot of people, we know, and it's obviously from a medical point of view, creates a structure in which we can effectively treat people. But we do know that our basic understanding about what makes us mentally ill is still very, very basic. And there is, it's probably a subject for another day, tiny amount spent on mental health research compared to the investment in lots of other aspects of research, of clinical research. So we're not moving very fast in our progression of treatment, understanding of conditions, and indeed better treatments. So that's a problem.
Thank you for that answer.
I'm aware Cassia wants to. Is it possible to bring Cassia in? She was wanting to ask a direct question. I don't know if you've got that message, Anthony.
I've not, sorry.
But Cassia's here. She's come. Are you able to join us, Cassia? You're muted at the moment. And it doesn't look like technically it's possible. I think there's a limit to how many people can actually join on audio.
Shall we go on to the next question?
Yeah, go on to see if we can sort
that. This question is about kind of what about fitness to practice and what diagnosis might affect a doctor with regards to the GMC?
So I think the issue here is set out by, we do quite a lot of work with the GMC, and GMC does set out quite clearly the sort of the context in which you need to think about this. It's not, I mean, the summary, and please do read the guidance, but the summary would be, it's not so much about the condition, it's about the state of your condition within that condition. So, so if, for example, you're experiencing a psychotic episode, then that's probably something that your employer needs to be aware of. And if you didn't disclose that, that would be, I think most people would consider that to be pretty unacceptable. But I think I'd follow the guidance rather than me giving you a more detailed answer.
I suppose to reassure somebody that there are lots of doctors that I know who have diagnosis of bipolar affective disorder, recurrent depressive disorder, schizophrenia even, and if you're well treated, there isn't really a reason you can't practice. I think it's about fitness to practice around you declaring when you're unwell, essentially. So I've got another question here is, what is your advice for doctors feeling overwhelmed at the thought of a second wave?
Well, I think you and the rest of the population would be the first thing. I think we're all coming to terms with this worry, and I think we really have to pay attention to the burnout that people reported during at the peak of the pandemic, and individuals. I sincerely hope that people will have had a chance to have taken a break, from that very, very intense period. If you haven't taken a break, I would take a break, if that's at all possible, because the greatest risks are, when you're constantly exposed to, this level of trauma, and you don't have the opportunity to step away for a little bit, then I would certainly do that. I hope that the learning from the last few months has been that you can put in place some local, very, very, very local, hyper-local protective ways of coping. We've heard some really interesting stories about the way that some shift debriefs have been run, where people have had a chance to go, I found that really hard, just to be really let go, really have a chance to, in a safe space, talk about how they're feeling. I do think it's really important that people have got access to, with both the things like Alpha Online, but also the internal services are available. Equip yourself with that knowledge, but also, do look after yourself. And this is going to be tough for everyone. And you know, most like pick the people that you trust. Who's the person that you know, who is the person on your speed dial that you're going to ring when you're feeling really overwhelmed, and almost set that up. You know, we hear a lot about people just saying, look, I really need somebody who I can just be that, who's going to be my listening ear and who's going to be there for me. Will you be that person? If you set that up in advance, you know, almost then you know that you've got the reassurance of knowing that you've got a place to go, and that might be a friend, it might be a family member, it might be a colleague, but of course, you know, it may also be, you may also need to seek professional help and support, and you know, I absolutely encourage people to do that.
Okay, so Paul, we've got 4 minutes left. I think maybe we've got time for one last question, then maybe some kind of closing remarks. Is that okay? Sure. So I apologise to anybody whose question we didn't get to, but I've got one last question. Is you've helped a number of workplaces promote mental health in their workforce. How do you think change relies on a top-down approach or a bottom-up approach?
Well, it's both.
Okay.
You've got to have, you know, both have got to be present in the system to be able to make it work. And that's why I think you guys are really, really important, actually. I think the UK Doc movement, you know, you're part of that bottom-up movement, and I'd really encourage you to do more of this, because I think that the top knows that this is a growing and important issue.
Yes.
The top doesn't always know what they need to do, and they'll be mightily pleased if there are a bunch of people coming up saying, how can we help?
Could you remind us of your 3 micro steps?
So my first micro step would be, how's your mental health today, and what are the 3 things you have, what are the 3 things that you do to look after your mental health? Second one would be, how do you know when you or a friend might be struggling? What are the things for you as an individual, and what are the things that you think somebody you're very close to would be a sign of them struggling? And thirdly, do you know where you would go when you're feeling unwell and you need help?
Thank you.
Can we squeeze in one more? Try and get one more.
Go on.
So I was interested in hearing about the support you gave the flight attendant as she was facing pressure. Doctors are also facing pressure, and occupational health may not be supportive, as many teams are operating from home. New doctors who started in August have few opportunities to meet permanent staff and other colleagues, and may feel sidelined. How do you think we might be able to help?
Really great, but around the country, people are walking into new workplaces, except they're not walking into a new workplace. They are, you know, tuning in on Zoom to new workplaces. And I think it's absolutely incumbent on the employers to bend over backwards to make people feel more welcome than they usually do. Now, I know enough junior doctors to know that sometimes the basic experience isn't always that great. But if ever there was a moment where you need to make sure that, you know, somebody, you know, buddy system is in place so that people can navigate their way around, or whatever it might be, you know, this is it. You know, it's so important, especially at this time.
Thank you.
Paul, thank you so much for joining us. I mean, it's a great start to the webinar series. I mean, I always think, because we're talking about things that we'd like to see happen and recognizing things that are taking place, but literally this conversation is one of the things that is proof that things are changing. And you talking and speaking in the way that you are just gives so much more momentum, and hopefully gives people thought to reflect on their own mental and emotional well-being, and if they are concerned, to reach out in the ways that you've described. And thank you again about both Mind, as for people to go to the Mind website, as well as our front line. They're both clearly very valuable in general, and certainly in this current period. But thank you for your time, Paul. It's been a great start to the webinar series. Thank you very much.
Well, thank you, and good luck for you, OK Doc. I hope it goes really well. Keep at it.
Thank you.